last-minute entry.
Good afternoon, everyone. My name is Dr. Shimpa, and my thesis topic was the study of ocular blood flow in primary open-angle glaucoma and normal tension glaucoma. Glaucoma is suspected to be a multifactorial disease with IOP-dependent and independent risk factors like decreased ocular blood flow, oxidative stress, decreased exoplasmic flow, and genetic background. A number of studies have generated strong evidence that decreased ocular blood flow may be a risk factor in the pathogenesis and progression of glaucoma. Under normal conditions, the relationship between the blood flow and perfusion pressure in the eye is auto-regulated. Auto-regulation is the capacity to maintain relatively constant level of blood flow in the presence of changes in ocular perfusion pressure and various metabolic demands. Ocular perfusion pressure plays a key role in the progression of diseases such as glaucoma and diabetic retinopathy. Aim of our study was to study ocular blood flow in POAG and NTG by color Doppler imaging to compare the end diastolic peak systolic velocity resistive index in central retinal posterior ciliary and ophthalmic artery with age-matched controls to establish any relation between ocular blood flow and structural and functional damage in glaucoma. Our study was carried out in the outpatient department of a tertiary eye hospital. It was a prospective cross-sectional study. 30 cases of NTG and POAG along with 30 controls were taken. Institution scientific and ethical guidelines were adhered and informed consent was taken from all the patients. Ocular blood flow was measured in this way. Color Doppler imaging was done for all the patients in the supine position with the eyes closed by a single observer. Sterile coupling gel was applied to the eyelids, and using a 9 MHz probe, the examination was carried out with the avoidance of undue manual pressure on the probe. B-scan imaging was done, and then color Doppler was started, and grayscale imaging in which the orbital anatomy were overviewed and the individual vessels were visualized using Doppler frequency shifts from the specific sample volume. This sample volume is placed over the vessel of interest and the frequency shifts are seen. In the central retinal artery, it is along with the central vein, and therefore there a double waveform was seen. In the short posterior ciliary artery, there were numerous short posterior ciliary artery, both temporal and nasal to the optic nerve. So this was unreliable. Ophthalmic artery was a reliable artery because it was very easy to find and it was temporal to the optic nerve. The velocities present in the sample volume follow the cardiac cycle, allowing measurement to be taken at the peak of systole, that was peak systolic velocity, and the lowest point of diastole, that is end diastolic velocity. Resistive index was calculated by subtracting end diastolic velocity from peak systolic velocity, dividing it by peak systolic velocity. It was a parameter ranging from 0 to 1. Normal was less than 0.7, more than 0.85 was considered higher, and it implies increased peripheral resistance causing direct impedance to ocular blood flow. Carotid artery was analyzed to rule out any stenosis and plaques. Inclusion criteria of our study were the newly diagnosed cases which were not on anti-glaucoma medications. Exclusion were with the secondary open angle glaucoma and angle closure glaucoma. Other with the ocular blood flow were diseases with ocular blood flow was compromised like diabetic retinopathy, CRVO, BRVO, arterial occlusion, post-trap patient, history of any retinal surgery, penetrating keratoplasties, patient on systemic beta blockers. Mean IOP was highest in the POAG group. RNFL thickness was comparable in the POAG and NTG. Severe field effects were seen in the POAG group. Resistive index was found to be highest in the central retinal artery of the NTG group, showing it was 0.9. In 73.3% of the cases of central retinal artery of NTG show resistive index 1, which implies significant stenosis of the vessel limit. Why resistive index of ophthalmic artery is significant? Because the results are reliable and reproducible, and it represents the main blood supply to the ocular structure. Resistive index in the NTG group were compared for the visual field effect, and there was 66% increase in the resistive index in the early visual field effect group, and 83.3% increase resistive index, that is more than 0.85 in the moderate visual field effect group. In POG, no such relationship was established. For the RNFL thickness, there was a negative correlation in the NTG, while in POG, no such significant relationship was established. Due to loss of neural tissue, there is a reduced metabolic demand, so few capillaries are required to nourish retinal ganglion cells, which lead to reduced blood flow to retinal ganglion cells. Reduction in retrobulbar and retinal blood flow over time were associated with structural glaucomatous progression, which was seen in Tope et al. No such relationship was established in the POAG for the RNFL thickness. Other parameter study was systolic blood pressure, diastolic blood pressure, mean ocular perfusion pressure, and mean ocular perfusion pressure fluctuation. There was a positive correlation between systolic blood pressure and resistive index in NTG. That is, there is a decrease in blood flow as systolic blood pressure increases because there is an increased perfusion of the ciliary body resulting in increased aqueous production and a higher IOP leading to decreased perfusion to the optic disc from sclerotic arterioles. For diastolic blood pressure, there was a negative correlation, that is decrease in ocular blood flow when diastolic pressure decreases in both NTG and POAG. Low diastolic pressure has been documented to a risk factor in open angle glaucoma. In conclusion, vascular factors are actively involved in the pathogenesis of NTG and POG. Role of ocular blood flow is more significant in NTG. Measuring ocular blood flow can play a role in early detection of glaucoma, as vascular disturbances were found in cases with early defects, and the weak relation between the structural loss and functional damage due to decrease in ocular blood flow appears to be neither a major consequence nor a strong cause of neural tissue loss. Thank you.
Thank you.